Okay, so this is the latest data that we have nationally in terms of HIV infection. I just want to walk you through it because there are several different pieces that this graph shows. First of all, if you look at the red line, what that shows is the number of new diagnoses of HIV, which are essentially flat over the last 10 years. So I'll come back to that in more detail in a minute. If you then look at the green line at the bottom of the graph, that's the number of individuals who have died from AIDS in the UK, and what you can see is that it is low, it's dropping slightly, but it's still flat. And the main reason for that is because people are being diagnosed with HIV late. If you then look at the blue line at the bottom, what you'll now see is that the blue line is overtaking the green line, and that more people now from HIV are dying not from AIDS, but from non-AIDS causes of death. And the number one of those is now chronic hepatitis, which of course is very relevant to what we're discussing today. And because that number of new diagnoses in the red line is high, and because the number of deaths is low, drop my microphone, then the total number of people in care in the blue bars is increasing year on year. Now, if we look at that red line in more detail, so breaking it up into different risk groups, again, we start to see a mixed picture here. If you look at the green line, these are individuals who have acquired their HIV overseas and then been diagnosed for the first time in the UK. And what you can see is that green line is dropping significantly, largely as a result in changes in immigration policy. If you then look at the red line, what you'll now see is that more heterosexual HIV transmission now is occurring within the UK rather than outside of the UK. So the epidemic is changing again. And most alarmingly, if you look at the blue line, what you'll see that's new diagnoses in men who have sex with men, and that is continuing to increase year on year. And each new year, the number of new diagnoses is the highest ever. And the provisional data, which will be released in a couple of weeks' time, suggests that the data for 2012 is again showing a further increase in men who have sex with men. Now, if you show this graph to an HIV audience, we think this is bad, that 24% of patients with HIV are unaware of their diagnosis. Now, ironically for this audience today, it's the other way around with hepatitis B, that only around 20 to 25% of patients with HIV are aware, with hepatitis B, are aware of their diagnosis. So for both infections, the importance of reducing undiagnosed infection is critical, but probably even more so for hepatitis B than for HIV. And another final graph in terms of national data, this is something that people are just starting to get a grip on. If you look at the blue bars at the top of the graph here, these are individuals that within HIV circles we call old. That is that they're aged over 50. I think some of us would choose to disagree with that definition of old. But nonetheless, the proportion of people with HIV who are old is increasing year on year, and is now around 25% of people with HIV are over 50. So it's a different patient group to that we typically think of in terms of having HIV infection. And HIV is not distributed evenly around the UK, it's very disproportionately affecting certain areas. And of note, in the darker blue there, right at the bottom, is Brighton and Hove, which has the highest prevalence of HIV outside of London within the UK. So our local data is in the clinic that I work at, the Lawson unit. We now follow up just over 2,100 patients, which is the largest HIV clinic outside of London. Locally, we have the highest HIV prevalence in Brighton and Hove outside of London. 80% within Brighton and Hove, as Jerry Tibble has already alluded to, are men who have sex with men, which is, again, that's much higher than the national figure, which is around 50%. And within Brighton, over 40% now are aged over 50 compared to 20% nationally. So we're seeing a different population group to that which we see elsewhere around the country. Importantly, 12% are co-infected with hepatitis C, and that number is increasing, and we have an ongoing epidemic of acute hepatitis C amongst HIV-positive men who have sex with men. And relevant to this evening, 6% of patients in Brighton, which compares to around 7% nationally, are co-infected with both hepatitis B and HIV, which is unsurprising given, as Dr. Tibble's already told you, that the routes of transmission are likely to be the same between the two different viruses. Now, the good news in terms of HIV, and this is perhaps what hepatitis B should be aspiring to, is in terms of outcome. So I'll walk you through this graph. If you look at this line here, this red line, this is the life expectancy of a woman without HIV within the UK. So if she is age 20, she would expect to live another 54 years. So she would expect to live to the age of 70 or 84, so 64 years, so 84. Men live slightly less long, so the life expectancy if you're male and you're 20 is around 58 years, so you would expect to live to around 78. Importantly, it's the green line here, which is individuals with HIV who start treatment early, and what you can start to see is that the green line now is almost the same as the life expectancy of men and women without HIV. And that becomes particularly marked the older you get, that in fact individuals with HIV now have essentially a normal life expectancy. And in fact, recent data from France and from Denmark suggests that if you have HIV infection, your life expectancy is actually better than the general population. Now, that's not to say that getting HIV is a good thing at all. That's presumably because people with HIV are accessing healthcare services and are benefiting from other healthcare interventions. So, coming back to this issue about HIV and hepatitis B infection, as I say, within the UK, around 7% of people will have both viruses. We know that if you have HIV infection, you are less likely to respond to hepatitis B vaccination. We've heard a lot about vaccination. You do less well in terms of vaccine response if you have HIV. Dr. Tibble told you that around 10 to 20% of people, if they acquire HIV as an adult, will clear hepatitis B spontaneously. This is far less likely to occur if you already have HIV infection, so you are much more likely to progress to chronic hepatitis B infection. And the levels of virus that are related to transmission and that are related to liver disease are significantly higher if you are HIV positive compared to if you were HIV negative. And the progression that Dr. Tibble talked you through is much more rapid and much more likely to occur if you have both viruses. So if you have HIV, you are far more likely to progress to cirrhosis, and this is far more likely to happen quickly, and you also have a much higher risk of liver cancer. So historically, it's been bad news. To have HIV and hepatitis B is essentially double trouble, if you like. I would say that now that we have more effective agents against both HIV and hepatitis B, a lot of those increased risks are probably significantly less than you would read about in the textbooks or in the journals. Now, the better news is on the other way round. If you look at the impact of having hepatitis B on HIV infection, there seems to be relatively little significant effect. So if you have hepatitis B and then you acquire HIV, your HIV does not progress more quickly. You're no less likely to respond to HIV therapy. There is some recent data suggesting, however, that perhaps your immune response to HIV therapy may be somewhat impaired if you also have hepatitis B. The less good news is that taking anti-HIV therapy, you're far more likely to have liver-related side effects if you also have hepatitis B. And when you start therapy, there is a phenomenon called immune reconstitution disease, where the body will sort of, if you like, turn on itself and start to fight the liver where the hepatitis B is, and that can cause significant liver damage during the first few weeks to months of starting HIV therapy. So, bringing all that together, what do we do in terms of management? And again, I think we're all giving the same message today, which is test, 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 and vaccinate. So the most important thing is to screen all HIV positive individuals for hepatitis B, and vice versa is to screen all individuals with hepatitis B for HIV. And not just to screen them once, but to repeat that annually if there is any risk of ongoing transmission. Secondly, again, is to vaccinate. We've heard about policies for vaccination. The policy if you have HIV infection is very clear. Everybody should be offered hepatitis B vaccination, and not only conventional vaccination, but actually with a double dose. We know that you're less likely to respond to vaccination, and it's been clearly proven that if you use a higher dose, then the vaccine is more likely to work. If it doesn't work, then again, the advice is very clear. You have a second go. If that doesn't work, the advice again is very clear. You have a third go once you're on anti-HIV therapy and your immune response is likely to be improved. And then you check that that vaccination has responded annually. In terms of clinical management, in somebody with HIV, the way that we usually tailor to whom we start therapy is using a marker of their immune response called their CD4 count. And the usual CD4 count at which you would start therapy within the UK at the moment is around 350. If somebody has hepatitis B, however, we recommend that you start much higher than that, and you start definitely with a CD4 count of 500, and possibly that you should consider therapy for HIV for every individual who also has hepatitis B infection, because we know that maintaining their immune response means that that risk of them progressing to cirrhosis or cancer is likely to be significantly reduced. Now, again, Dr. Tibble alluded to the fact that we do have different drugs. This is a list of drugs that work for HIV, and all the ones that are asterisked also work against hepatitis B. So the good news is that you can often get away with treating both viruses with the same drugs. So rather than needing 5 drugs to treat 2 different viruses, you can normally get away with using 3 drugs, 2 which work against hepatitis B and HIV, and a third drug to further work against HIV. So because these drugs work against both viruses and we need to try and avoid the resistance that Dr. Tibble told you about, then the key is that you need to know whether people have each virus separately or both together. So again, you need to know whether every individual that you're going to treat for HIV has hepatitis B, and conversely, you need to know whether every individual with hepatitis B has HIV before you start to treat their hepatitis B, because otherwise you will be under-treating one or other virus, and that will result in viral resistance. And then finally, in terms of sort of other management issues, I think for the patient with HIV and for hepatitis B, it's important that they are seen by either an expert clinician in both diseases or by a combined approach with both a liver specialist and an HIV specialist at the same time. As we've heard before, we need to be perhaps more proactive in terms of staging liver disease, so biopsies we've heard about, but also newer techniques such as FibroScan. There are options therapeutically if an individual, and some people don't want to take HIV therapy, there are other options that we can consider. And it's important that we continue to monitor closely the effectiveness of both therapies, and particularly to check for safety and tolerability, as many patients are going to be taking at least 3 drug therapy for the rest of their life. So it's very important that we try and tailor that therapy, not just against the viruses, but also to be consistent with the individual's preferences. And then finally, in terms of Brighton and where we stand in terms of HIV and hepatitis B, again, I think as we've heard, nationally we have a significant issue in terms of undiagnosed infection for HIV. We know it's around 20% locally, and that's despite multiple local initiatives, but they do seem to be working. So now within Brighton, you not only can get tested for HIV within the STD clinic, you're now also routinely offered an HIV test with your GP. If you're admitted to hospital, the Terence Higgins Trust run community-based HIV testing services. We test people in gay saunas, in pharmacies, and as of last week, we're now sending out home testing kits so that people can test for HIV in their own home if they prefer to do that rather than in a healthcare facility. And I think the irony there is that it's all about HIV, and really perhaps we should be using the same opportunities to test for hepatitis B and indeed hepatitis C at the same time, given that many of the risk factors for each of the viruses are the same. Secondly is that there's ongoing HIV and clearly hepatitis B transmission, particularly locally amongst men who have sex with men, and therefore again significant need to reduce infection. We need to improve access to hepatitis B infection, and we need to be wary that in the future and within the next 1 to 2 years, we're going to start having generic anti-HIV drugs, which are going to significantly reduce the cost of HIV therapy, but we need to make sure that that's not to the detriment of any hepatitis B activity if that's needed. So we need to argue to make sure that our patients get access to the best therapy, even if it's not the cheapest therapy. And I'll stop there. Thank you.